All right. Well, look, here they are. We've got two excellent debaters and experts in the hematologic malignancy space. One of them claims that he also plays guitar and stuff like that and is wearing an AC/DC shirt. And Aaron, introduce yourself to listeners. You're very prolific on Twitter. As part of your introduction, I'd like to know, how did you become Papa Heme?
So, well, first, Aaron Goodman, nice to meet everyone who I don't already know. I work at UCSD. I'm in the division of bone marrow transplant, but I also treat patients who don't need transplants. I'm involved in the fellowship education program, and I treat all sorts of blood cancers. It's not just one specific. So myeloma, lymphomas, acute leukemias. So kind of a bread and butter malignant hematologist. Papa Heme, someone called me Papa one time, and I liked it, and then it was like 10 weeks ago, and I was with my wife, and my dad actually, I was visiting, so we were just both been vaccinated, and I said, I'm going to put this in quotations, and then they both made fun of me, quite a lot actually, and then my coworkers found out, which I was actually kind of embarrassed about a little bit when they found out, because they started calling me at work and the nurses, and then I just, now I own it, and now 10 weeks, literally, I saw my dad again. He's like, I was there for the creation of Papa Heme. But it was a Twitter, someone who follows me recommended it, and it stuck. And I'm a father. I have 3 young girls, and that's a lot of, actually, the hardest part of my job is taking care of them.
It is pretty fun. I do call you Papa now. It's kind of funny, actually. It is good. You put a lot of quizzes on Twitter, which are really a lot of fun. Just keep doing this. I love being challenged. I'll admit, so far I have not gotten any gold star from Papa, but I don't like to admit that on Twitter.
Yeah, you haven't got one right yet that I'm aware of, but that's okay. Keep trying.
No, yeah, no, I keep trying. I'm not I haven't gotten one. I know. The Papa level, I never get the Papa level. I get, a few levels down. Matt, introduce yourself and where you practice and where you are.
Sure, thanks, Shadi. So I'm Matt Wilson. So I'm a hematology final year, what we call registrar in the UK. So a different system to the US. So I'm in my last few months of training before I become a consultant, which I guess you guys would call attending. Is that correct? I work in Glasgow in the UK, in the Beatson West of Scotland Cancer Centre. So it's a big catchment and big lymphoma practice. But I do lymphoma is my subspecialty interest, but I'm involved in treating all other hemonc diagnoses as well. CNS prophylaxis. I during my little lymphoma fellowship I did a couple of years ago, I got involved in this really when I got an opportunity to co-author our British Society of Hematology updated guideline on CNS prophylaxis. So that's when I really got interested in really delved into the data or maybe lack of data as we'll go on to discuss.
But let's set the stage though. I mean, we're going to talk about CNS prophylaxis in diffuse large B-cell lymphoma, right? I mean, we're going to set the stage a little bit because not all of the listeners obviously are prolific in lymphoid malignancies. We have a lot of just general oncologists as well as fellows in training and so forth. So what I want to just start with is when did this become a topic? Like, in other words, why in diffuse large B-cell lymphoma CNS prophylaxis became a topic? Who wants to tackle that?
Yeah, sure. Do you want me to do that, Aaron?
Go ahead.
Yeah, go for it.
Yeah, so diffuse large B-cell lymphoma, commonest type of non-Hodgkin's lymphoma, is an aggressive but curable for the majority lymphoma. And we've got a very well-established treatment for the majority of patients, which continues to be proven to be the best treatment, and nothing seems to be beating it with R-CHOP. And that will cure the majority, in the region of about 2/3 of patients. But there remains a significant proportion where that treatment will fail, and they may relapse with lymphoma systemically, or they may either be relapsed or not respond to treatment. But there's also a small proportion where they will relapse within the central nervous system, and that proportion is in this area in the rituximab beer is probably around about 5% overall. But so it is a small percentage of patients overall, but we know now that there are certain patients who are definitely at much higher risk, as we'll maybe talk about. And I think the essence of all this is that, unfortunately, relapsing within the central nervous system is a fairly devastating event for patients and almost universally fatal, unfortunately, despite all the advances that we've seen. And so, yeah, the idea has been, how do we incorporate something into our treatment that will maybe prevent this rare but devastating event? And that's where CNS prophylaxis has come into it. So how can we deliver some sort of treatment that will penetrate the CNS and hopefully prevent this fairly awful event from happening?
So, Aaron, so we are talking about the 5% of patients then of diffuse large B-cell lymphoma that might have higher risk of developing CNS disease. That's the subset of patients we're talking about. Back when you were in training and so forth, what was the classic teaching as to who are these patients and how were you trained when you were a fellow into how to manage this?
Yeah, so, and we'll get into our feelings and beliefs on this later into the debate, but, I was trained CNS prophylaxis. That was part of my training. And I never, as a fellow, as a trainee, you don't question much. It wasn't until more of my attending years. But basically, anyone deemed high risk of CNS relapse, we gave intrathecal. We actually, in my training, we didn't do much, if any, high-dose methotrexate CNS prophylaxis. So intrathecal, usually 4 LPs with, methotrexate 12 to 15 milligrams. And what we deemed high risk actually varied by attending. But for the patients with HIV, were all deemed, and I'm talking strictly DLBCL, not Burkitt's or ALL. So HIV, DLBCL were deemed high risk. During my training, we learned about the CNS IPI, which is basically just the standard IPI plus kidney and adrenal involvement. And if you have enough of those points, you are segregated into low, intermediate, and high risk. Low being about a 1% risk of CNS relapse, intermediate being, I think, 3%, and then high risk 10%. So, somewhere in the middle of my training, that came to be kind of, we would calculate this, and those 10% or more was deemed, we use that as our arbitrary cutoff as who we defined high risk. But then it got more complicated, at least for me. I started seeing, patients who didn't have all the traditional risk factors, but maybe they had breast involvement by their lymphoma. So some attendings called that high risk, and they got intrathecal chemotherapy, or a few extranodal sites, or super high LDH. Those were given, or maybe a little epidural involvement without frank CNS involvement. And then it even got, to me, started getting a little bit more crazy. What about BCL2 MYC expression? Let's just call those high risk. They have a higher risk of relapse. So we started giving them. I feel like I was giving CNS prophylaxis to a lot of my patients for a risk of something that was rather small.
Yeah, that's a good point. So, Matt, I mean, the issue becomes, well, let's backtrack. Let's define the high risk patient population, because I was also, during my training, which was way before both of your trainings, I was really brought up that CNS prophylaxis should be given with anyone with high LDH and extranodal site. That's one. The other thing was anybody with proximity to the CNS, so tonsillar involvement, epidural, sinus involvement, it's close enough, so we just have to give it. And then lastly, was with the double hit lymphoma, whether it's chromosomal cytogenetics or double expressors, that we have to do that. And I admit that I was giving intrathecal, and then I migrated into high dose methotrexate towards the end. So let's first of all agree, who are the high risk patients of CNS disease? And then we're going to debate, after we agree who are they, whether they should get anything or not.
Yeah, sure. So, yeah, this is maybe an area of this whole topic where we have moved on, certainly, in identifying these high-risk patients, but it remains imperfect, definitely, as we'll discuss. So, we in the UK were similar. We used to, the guidance used to be to give intrathecals, and then only recently have we updated the guidelines to say high-dose methotrexate. And in terms of who we used to give it to, similarly, it was anyone with more than one extranodal site and raised LDH. Or involvement of the many sites that you mentioned there, Chadi. But I think we have seen over the years literature to say that a lot of these extranodal sites were traditionally deemed to be high risk, or were actually really sites that were just associated with advanced stage high risk disease anyway. And actually, independently, these sites don't bear out as independent risk factors for the majority of them. So things like craniofacial or sinus involvement, these kind of things now, I think we've established that in themselves are not independent risk factors. We will see them in patients with other high risk factors for CNS relapse. And the CNS IPI, I think has been an advance, but it does remain imperfect. So Aaron summarized it there, but I mean, we need to remember that the high risk group, the risk is 10% overall. But I think it's like 40% of CNS relapses will occur out with a high risk group. So we're definitely not capturing them all just with the CNS IPI. So clearly there are still other characteristics that we need to think about. I think certain high risk sites, I think we can agree probably are still independently high enough risk. So renal obviously came out in the CNS IPI. I think we could agree on that. The data for things like uterine and breast, there are mainly retrospective studies suggesting very high rates of these sites, in the region of 20 to 30%. And so, we would still consider offering it to these patients, but the data is not great, but I think there's enough to say they are probably still high risk. And then, we get on to the biological risk factors, which is, we talked about, double hit lymphomas, and even used to be thought just a mixed translocation in itself was high enough risk. And again, I think that risk has been overestimated over the years. Initially, as you know, in the DLBCL trials, it was only really the high risk patients who were getting FISH performed. So FISH wasn't really performed uniformly, so we probably weren't picking up who all these double hit patients were. And I think initially the kind of risk of CNS relapse in these patients was overestimated, and now there's more recent data to suggest from some of the big prospective trials, even the Goya trial, that probably that risk is lower with double hit lymphomas, and maybe possibly more in the region of kind of 5%. So we have stopped using double hit in itself as a reason to give CNS prophylaxis. A lot of these double hit patients, as you know, present with other high risk features that we would incorporate, but in itself, we don't consider it an independent risk factor.
Right. And we haven't gone even to giving CNS prophylaxis. I think I was trying to identify who are the high risk patient population to consider giving CNS prophylaxis. Aaron, so these are the high risk patients.
Well, I just want to say, first, I think my first argument is we can't really agree on who the high risk patients are. So again, I think it's more of an approach just how we practice oncology or hematology in general, for me, at least with additive therapies, especially to a large majority of patients who are cured, whether it's in the maintenance setting or CNS prophylaxis, I need to be fairly confident that I'm helping these patients out. So first, I don't think anyone can really agree who the high risk are. And I agree with all the things that Matt said, but we really don't know for sure. I think the best data we have is the CNS IPI. It's at least the most controlled. So if we want to arbitrarily say that a risk of CNS relapse of 10% or more is high risk, then we can do it. But as we said, we are clearly missing some people who are going to relapse. And then the positive predictive value of the CNS IPI, I think it's only like 10%. So we already have to accept that we're over-treating 90% of patients in the best case scenario. So I think that's one of my main arguments. Number one is the lack of agreement on high risk of CNS relapse. My second, point is, I think if we're going to accept the fact that an intervention at diagnosis or during the early treatment period benefits these patients, meaning with CNS-directed therapy, whether it be IT or high-dose methotrexate, we are kind of assuming that there is occult CNS involvement at baseline, at least biologically. So that we have to accept, and I don't, is that true or not? No one knows. And then we have to accept the fact, I think what I just brought up is that the majority will be over-treated. And we gave IT methotrexate, and I think you said you guys were giving it too. And then all of a sudden we switched to high-dose methotrexate. And I don't, for me, when I switched to high-dose methotrexate, although now I do none, it was literally just reading a Blood How I Treat article. I think it was in 2017. And I read the How I Treat article. It was pure ignorance on my behalf. I think the author pointed out that the majority of CNS relapses are parenchymal, 58%, and then an additional 12% are in the meninges and parenchymal. And I was like, this makes, why the hell am I giving IT methotrexate if 70-80% of these are intraparenchymal? So that is the reason why I switched. But I'm curious
Aaron,
why you guys switched over too.
But Aaron, let's agree on a couple of things. Can we agree that we cannot not every practice that we do in oncology is supported by a prospective randomized control trial? Can we agree on that?
Yes, 100%.
Okay. Good. So we agree on that. Many examples exist.
Although this could be studied if we really wanted to.
That's my question to you is, how would you, what kind of trial would you really do to answer a question like this definitively? I'm struggling with that particular. You would take the high risk. Design the trial.
Before I design the trial, I think another one of my arguments is I think prophylaxis is not the right strategy for these patients. I think better systemic control is really going to be the best practice to preventing CNS relapse. If we look at the addition of rituximab to CHOP, the rates of CNS relapse, I don't know the exact percents, but they went down, and I think more closer to 1 to 2%. And since the addition of rituximab, we have failed to improve on our CHOP. I think we'll hopefully get there, maybe with some of the bispecifics and more novel approaches. It's clearly not intensifying chemotherapy. That's a whole nother talk, and I don't want to talk about it. I think with the addition of some of these novel, so I think if we can control systemic disease, we can prevent CNS relapse. So yes, we could design a prospective trial looking at CNS prophylaxis, or we could do what we're largely already trying to do in the field, is get better frontline trials. And man, we have tried numerous noble efforts. It just hasn't been effective yet. So, I mean, I could tell you, I mean, I think actually designing that trial is not super necessary right now, because we're already doing what needs to be done, which is designing better frontline trials. And as you said, I think some of the traditional risk factors for CNS relapse, as Matt brought up, all of it kind of intertwines with a huge disease burden at baseline. You know, they have those really sick, numerous extranodal sites, high LDH, which is more the reason why I think it supports better systemic control will be the answer, at least in my opinion.
Matt?
Yeah. I mean, I can't argue with any of that. I think that's true. We know that a lot of, probably 40 to 50% of CNS relapses occur in the setting of active or relapsed systemic disease as well. So I think, yes, that does suggest a failure of systemic therapy. But, you know, it comes that we within the CNS IPI, going back to that, you know, the patients with a CNS IPI of 6, they've got a 30% risk of CNS relapse, you know, CNS IPI of 5, like 15%. So it all comes down to a balance of risk, doesn't it? Because, you know, what we're trying to prevent for these patients is absolutely devastating and fatal. And, you know, we know that patients with active CNS involvement, they've been neglected over the years in terms of involvement in trials, and it's often an exclusion criteria for trials. You know, it's an exclusion criteria for CAR T therapy, certainly over here anyway. And yes, it is a very rare event, but it's devastating. And I think I can't argue with everything that Aaron said. We need to get a lot better at this. We need to get better at picking out these patients. But there's no doubt that these patients exist. There are patients who are really exceptionally high risk. And I think we need to just get better at selecting them. And yes, we probably need to find a better way of preventing it. But right now, there is nothing that I've seen that is better. And we do have some, albeit poor data, to support high-dose methotrexate.
So Matt, can I let me maybe, I know I'm moderating this. I'm struck by one thing. I mean, just because we have a high risk of something, it doesn't mean we could do much about it. I mean, I think we could in certain situations, right? But there are times where you just do your best with the treatment, and you may have a high 30% risk of a particular toxicity. And that's really there's nothing you could do to mitigate that risk. So I see your point that the risk is very high. But if the risk is high, what's the evidence that we could diminish that risk? And then what type of study would you show Aaron to try to convince him that doing this is helping these patients?
Yeah, so we can all agree there has not been a gold standard study to demonstrate a benefit by high-dose methotrexate. There's never been a prospective randomized trial to demonstrate a benefit, which I know we would all want. I think the problem with trying to design a trial like that would be very, very difficult because it comes down to how rare this event is and the numbers you would require to have sufficient power in your trial to demonstrate a benefit or not of a prophylactic strategy would be enormous. And I think that's part of the reason why we haven't seen a prospective trial yet, and maybe we never will. So it comes back to your point, we have to rely on the best evidence that we have and try and make a kind of pragmatic decision about it. And what we know is that there are some retrospective data sets, acknowledge that, demonstrating a benefit of high-dose methotrexate. So there was, to go through a few, so there's an Italian series from Andre Ferreri from a few years ago. They give high-dose methotrexate at the end of R-CHOP therapy, relatively small numbers, but to a high-risk patient group, and they had no CNS relapses within their cohort. The Massachusetts study from Abramson that kind of was until recently was the only published experience of intercalating high-dose methotrexate with R-CHOP. Again, a relatively high-risk patient group. They gave high-dose methotrexate in between cycles of R-CHOP to high-risk patients and had a CNS relapse risk of, I think, between 3 and 5% in a high-risk group. And then another Australian study a few years ago by Chan Che, who's done a lot of work in this area, comparing high-dose methotrexate mainly with intrathecals as well, it must be said, versus intrathecals alone versus nothing. And again, demonstrating a statistically lower CNS relapse risk in those who have high-dose methotrexate. So none of these studies by themselves are definitive by any stretch of the imagination, but they are what we have at the minute. And we'll come on to talk about the more recent studies that have kind of triggered all this that are now starting to question it. But in my mind, nothing has come out that is sufficient to kind of override the kind of cumulative evidence that we have already, suggesting high-dose methotrexate may help.
Aaron, we don't have one powerful study that answered the question definitively, but we have a collective or totality of evidence that support maybe we reduce the risk and help patients. What are your thoughts there? Do you want survival benefit? Is that what you're looking at, or?
Ideally, but I agree. I think the endpoint of preventing a CNS relapse, even if they're going to be cured, is very important, right? A CNS relapse, if it doesn't result in death, that means they got a lot of chemo and probably a stem cell transplantation. So I think I agree completely that we need to do what we can to prevent that. But as you know, this is a super rare event, okay? And a lot of this super rare event, like 1 to 2% if you look at everything in aggregate in the rituximab era. And a lot of these CNS relapses are also going to relapse systemically at the same time. So whether we prevented the CNS, if they still relapse systemically, I don't know how much we help that patient. So and all the data you cited, it's retrospective, and I think I just don't really rely on retrospective data anymore when it comes for treatment for the large part. And again, because I know 100%, I need no study to be run that high-dose methotrexate and or intrathecal methotrexate results in toxicity, because it does. There's some expense, and it's a pain in the butt for patients. I don't want an LP. If I didn't need one, I would. No, it's definitely not with intrathecal methotrexate. I've seen neuropathy after that. And high-dose methotrexate, this isn't like a benign. If it was given a statin or something that was a nothing, then I would be okay maybe with the retrospective data. But this is high-dose methotrexate. And for the most part, it goes okay, although that still requires, a hospitalization. I don't want to be hospitalized. That's like a whole new dynamic to DLBCL. If most don't need to be hospitalized and then get cured. I don't know, that's a few hospitalizations, depending on how many we do, which is another argument. Do we do 1? Do we do 2? Do we do 4? Maybe 6 is the magic number. I don't know I don't know what to do. So, and it's toxic, high-dose methotrexate. Even if it goes wrong 1 in 100 times, it can go really, really wrong, okay? And really hurt the kidneys, and there's cumulative nephrotoxicity. So the intervention is not benign. So if we're going to do a non-benign, expensive, and annoying intervention in a large group of patients who don't need it, with this questionable, if any, it's going to be a small benefit if it's real, you can't convince me to do it. And I think that's just, I don't think it's wrong to do it. And I think these are all discussions you have to have with patients. Although I've been framing it kind of just how I framed it to you guys. And I think it has what patients do is largely dependent on how the oncologist frames it. But I frame it like that. And I think I'm being truthful. And since over the last year, especially since some of the ASH abstracts, I've stopped doing it. And I haven't had a patient yet say, I disagree and want to do it. I still haven't yet, and I don't know what I'll do, and maybe this is another debate, a testicular lymphoma, what I would do there. I feel like it would be unethical to give high dose, not give CNS prophylaxis, but then the other part of me is like, I don't really know what's helping, so I don't know what I'll do in that situation. So to summarize, I can't do it based off the current data, even if they generally summarize that it maybe benefits these patients.
But Matt, are there any other data that we are going to get beyond what we have now in April 2021? I mean, I'll take Aaron's argument, and maybe if there's something that we're going to get in the next year, and I will say, okay, current data doesn't exist. Maybe in a year we'll have something to resolve this. But if we're not going to get anything, this is as best as it gets. I still think we need to have, I don't know, a consensus or something, to help patients.
Yeah. So, going back to a couple of things Aaron said, we can agree on intrathecals. I think we can all agree on that, right? I think that the evidence is there now to say that they don't help. They can actually harm, and I think we can accept that we can forget about intrathecals. In terms of your question, Chadi, so I think there will be more data. We are leading a study. So we published our UK study last year of comparing intercalated to end of treatment high dose methotrexate. So that study was designed with under the presumption that high dose methotrexate works. Okay, so we weren't trying to prove whether high dose methotrexate works or not. We were trying to see when the best time was to deliver it, and we showed that yes, if you tried to intercalate it with R-CHOP, it did cause more delays and more toxicity. And we didn't actually demonstrate any difference in CNS relapse between the two delivery methods. But and actually, another important point was that our CNS relapse risk overall for this was a very high risk patient group, was about 6%. So no, it wasn't designed to answer does high dose methotrexate work, but certainly it was a low rate of relapse for a high risk group. But we knew, the numbers we're talking about are small, and it keeps coming back to the statistical issue whereby if you really want to demonstrate benefit of something, you need big numbers. So we have expanded our study this year to sites all over the world. Really, we're trying to get a big database of high dose methotrexate treated patients, and we hope to present that at the end of the year, potentially at ASH. So there will be that, and I also am aware of that.
Aaron, what do you think of what Matt is doing with this large retrospective? You said you won't buy anything retrospective.
Yeah, I probably won't buy it still unless it's like really, large
numbers.
But
Aaron, you did just say that you've been influenced by the recent, the stuff presented at ASH last year. That was all retrospective, but you referenced that's influencing your practice.
That's a good point. You're pointing out a little bit of my hypocrisy. That's good, but for me to for the level of evidence I need to not give a therapy is less than I need to give a therapy. For the reason being, giving a therapy is a known 100% increase in toxicity and expense. So I personally require, at least I've come to this conclusion. This wasn't me always. This took years of me doing this long enough, but I require a higher level of data to give additional therapy, knowing I'm giving the majority of this therapy to cured individuals who do not need it. I think we can agree on that. The majority of patients who get high dose methotrexate will be cured and not need it. And because of that, I require a higher level of data. Whether that's wrong or not, I don't know, but that's a belief I have.
Yeah, but it's a little bit like saying, probably a lot of patients we give 6 cycles of R-CHOP to will be cured with 3 or 4. We don't know. We give them all 6. They probably don't all need it, but it's a little bit like that. And the other thing is that you talk about,
we have curative lots of trials. Yes, 4 might be better, but that's in the setting where I know 6 cures X amount of % of patients. I don't know that 4 does, and this is a different scenario. This is to prevent. This is giving people who don't have disease. That's a different. The CHOP, they have disease, while this is giving people who don't have CNS disease a therapy to prevent it. So slightly different. I agree.
I think what Matt is highlighting is there are so many examples we could bring that we just don't have 100% evidence to justify this.
And I think the other thing is that, Aaron, your point, I absolutely agree. We need to be speaking to the patients about this and presenting the pros and cons and the risks. But, ultimately they're going to, it's hard enough for us as lymphoma clinicians to know what the right thing to do here is. So it's very hard to ask patients to make decisions about this. And ultimately, as I'm sure you'll see, they will come to us and say, well, what do you think I should do? And if we've got a patient with a CNS IPI of 5 who's, young, fit enough, you think, to tolerate high-dose methotrexate, and you give them nothing, and they relapse in the CNS at some point, it might have happened anyway. We just don't know. But personally, I would feel that, well, there may have been something we could have done. And for that patient, that's kind of my worry, is that we're not giving this small, albeit small proportion of patients who may benefit. We're doing them a disservice at the minute with the data that we have.
Yes, no, that's a devastating worry, and I agree, but my brain goes the opposite, and I would feel worse if I gave that same individual high-dose methotrexate and I screwed up their kidneys for good. And I would feel, personally, I always feel worse in any setting of oncology. I always feel personally worse if I cause the harm than the disease. Although you're right, lack of treatment could cause harm from disease, but in this setting, this is to prevent. So a not known disease. So again, I couldn't live with myself if I gave high-dose methotrexate and caused irreversible harm for something they almost certainly didn't need.
Yeah, I mean,
what are the chances? What are the chances that the toxicity that Aaron is worried about indeed happens? Because if you give it with proper precautions, it shouldn't happen, no?
Yeah, I mean, I agree with you, Aaron. Like, the high-dose methotrexate is a toxic therapy, and I think it's very important to select your patients appropriately. With ensuring their baseline renal function is satisfactory, that they can cope with the fluid shifts involved, that that they're generally fit enough for it. And yes, significant renal injury happens. It was actually, for what it's worth, in our study, our UK study, it was actually relatively low. It was less than 5% of all high-dose methotrexate cycles delivered resulted in significant renal toxicity. But I absolutely agree, it's there. You really have to pick your patients properly. But everything that we give has risks of toxicity. But I can't disagree. It's a treatment that you really have to pick your patients very carefully for, because it's not without potential harm.
Aaron, what were the data at the last ASH meeting that made you feel stronger against CNS prophylaxis? For listeners, there were a couple of studies probably came out at ASH of this past year that strengthened Aaron's position and weakened Matt's position. So what are these trials?
Yeah, I don't know the data off the top of my head. Maybe I think it might have been out of Matt's group, but the retrospective study where they looked at high-dose methotrexate amongst patients with fairly high risk of CNS relapse. I don't know the numbers, but they were large numbers. It was just published also in article form, and it basically showed no benefit in a large series. Again, retrospective. And then also the paper that Matt brought up, I believe it's published, where they looked at high-dose methotrexate. I was always under the pressure, if we're going to give it, it's good to give it right away when you have the disease burden that's high and really intercalated on day 14. So you give R-CHOP on day 1, and then on day 14 or 15, give the high-dose methotrexate, and you do that the first few cycles. And then their group showed that there was no difference between doing it up front as opposed to doing it delayed at the end. So I think those two studies were enough that it further, and actually a lot of it just made me think about this more. I just didn't think much about high-dose methotrexate or IT prophylaxis. But when I thought about it more and how it aligned with my views of over-treatment is what we do a lot of in oncology, and we should do efforts to minimize that. That's how I changed my mind.
The solution is to let Aaron think less. So Matt, how do you position your thoughts about CNS prophylaxis in view of the two recent studies that just Aaron mentioned?
Yeah, sure. So the second one you mentioned, Aaron, was our study that we published in Blood Advances last year. So, and as I described, we appeared to show that giving high-dose methotrexate at the end of treatment didn't increase the risk of CNS relapse. But we have been very cautious about saying that is definitive because of the numbers involved, and that's why we're trying to expand it. Because the rationale, as Aaron said, is that we know that most CNS relapses occur. The median is about 68 months from diagnosis. So of course you'd want to get your treatment in early, but we maybe are starting to show that giving it early perhaps is not particularly a benefit over giving it at the end of treatment, but we may know that a little bit more clear later this year. The data published presented at ASH, and then the study published recently in the American Journal of Hematology from the Canadian group. So first of all, without wanting to sound like I'm just criticizing the whole paper, I think kudos to them for carrying this out, having tried to, having been involved in doing these big data collection studies in CNS prophylaxis, it's a big undertaking, and I think they did a great job. But I think we need to highlight some of the problems with this data. So they basically, I think it was a 2-center study in Canada. They collected data on patients and meeting their criteria for high risk of CNS relapse, which were fairly, standard agreed criteria. And then they then did various analyses, multivariable analyses, looking at whether high-dose methotrexate influenced CNS relapse. But in the end, they actually only had 115 patients who had high-dose methotrexate. So their group of high-risk patients was about 350, but only 115 of those had high-dose methotrexate. The rest didn't. And it wasn't really clear why the rest didn't. They met their criteria, but they didn't get it. So that in itself, really suggests some significant selection bias going on, doesn't it? And yes, and the other thing is that high-dose methotrexate group, the ones who got it, they definitely had higher risk features. So they had more patients with more than one extranodal site. We know that's definitely a risk factor. They had more patients with renal involvement. So, we're not looking, I think, here at equal groups. And yes, they seem to show that high-dose methotrexate didn't reduce that risk of CNS relapse. That was kind of their conclusion. But those are the significant caveats. And there was also a few other things, that quite a lot of the patients in the high-dose methotrexate group, actually, I think almost half of them were consolidated with an auto. So that's got to be a confounding variable. A reasonable portion actually got our products MRI back. They didn't just get our chop. So I think it's a useful study. We just have to keep adding to the evidence as much as we can. But it comes back to, for me, it's not enough to say we should be stopping giving this.
But one argument I want to make is we know that a bigger competing risk of death for those in CR of DLBCL is relapsed DLBCL systemically. So
yeah,
I could argue, let's just give more therapy. Yeah, let's consolidate them with whatever you want to do. We might prevent a few percent of those, but we don't. So, right, you could do an auto, and maybe benefit the PFS in that high risk group if you look at the random. But we don't, or we could do additional therapy. And then the other argument I want to make is I am hopeful that with the bispecifics or some of the new approaches we're going to incorporate in the front line with the ongoing trials, that we will finally improve upon our CHOP. Let's just say we improve upon it by 5 to 10%. Well, then what do we do with are we going to continue? I mean, do we have to start over with high-dose methotrexate? And, so those types of things. So I think, I will admit, I think your strong point is, you're right. And that young person who's probably going to fly through high-dose methotrexate with minimal issues, that's super high risk, then it's really not such a big deal. But I still don't think I'm going to change. I will discuss it with everyone. I won't recommend it, but if they strongly disagree with me and want to seek a second opinion, I will always say, it's perfectly reasonable to disagree with my recommendation on that.
Aaron, let me ask you a quick question.
Yeah.
I mean, like, just for example, because there are some variations even within the same faculty members at the same institution. Like, let's say at your institution, if there are whoever is seeing malignant hematology, is there a consensus right now at your institution that everybody believes no CNS prophylaxis, or do you see variation even at your own center across other centers? Because clearly the question is not resolved in the mind of everyone.
There is variation in our group. Again, we when I go to the tumor board, if it comes up as a recommendation, I just say no, but I don't know what the individual doctor ends up doing. But there are people who believe in it. There are some that still give IT methotrexate. And again, I know we all uniformly now agree that IT methotrexate's no benefit, not the best data anyways. But, why did we all of a sudden arrive at that? And now we're all about high-dose methotrexate. We'll just wait for the more data on high-dose methotrexate, and then we'll change our mind on that and say that they need some other therapy. So again, it's just, there is no variability in practice. And for the community physicians, who may not have as much, giving high-dose methotrexate, we have a dedicated leukemia lymphoma service. It's fairly straightforward for us to do it. But I would suspect it less volume centers who come to us for a second opinion, and then we say, oh, I recommend high-dose this. Here you go deal with it. We might be doing more harm in those particular scenarios.
So let's try to do this, because I think that, again, there's probably limited future information that we're going to get, I would think. I think my sense is that the field of lymphoma is kind of moving to different questions. I tend to, I like what Aaron is saying about better systemic therapy. He's a little bit more optimistic than me. I actually don't see a regimen that's going to improve over R-CHOP. I think everything has failed so far. I'm not seeing anything that is making me believe R-CHOP will lose anytime soon. I would love to. But Matt, you are pro CNS prophylaxis. Give me an example of a patient in that high-risk group that you would not give CNS prophylaxis to. And I'm going to ask the same question of Aaron, where I want to challenge Aaron to give me a phenotype of a patient that he would at least consider giving CNS prophylaxis to.
Yeah, that's a good question. And so I'll give you an example. And what looking at the CNS IPI, I think we have to consider that age is a factor in the CNS IPI, especially age over 60. So a lot of older patients with diffuse large B-cell lymphoma will end up with high CNS IPI because they're already scoring one factor for age. But we know that the older the patient, and particularly when they get to over 60, the less likely they are to be able to tolerate high-dose methotrexate. So, for example, a patient who is 70 years old, let's say, who has a CNS IPI of 4, one because of their age, maybe they've got 2 extranodal sites, advanced stage disease, and a LDH that's like, a bit above normal. There you go. They've got a CNS IPI of 4. And you might say, well, they should be offered CNS prophylaxis, but Aaron's point, this is a toxic therapy, and ultimately the biggest risk to this patient is not CNS relapse. The biggest risk is systemic failure, and we do not want to compromise their R-CHOP delivery. So that is a patient where I would think very carefully about giving them high-dose methotrexate at all. Certainly would probably not try and intercalate it with their R-CHOP, because I think you're asking for problems there probably in terms of interrupting their systemic therapy, and would also think carefully about giving it at all within the end of treatment. And equally, older patients, once you get beyond 70, 75, really you've got to be thinking very carefully about giving them any CNS prophylaxis at all. So I guess that would be my example.
Seems like the age is a major factor in Matt's phenotype, at least. Aaron, is there a phenotype of a patient that comes into your clinic where at least you would think twice and you would say, maybe I should give this man or woman CNS prophylaxis? Any phenotype?
Well, the youngest age I treat is 18. So let's just say an 18-year-old who's got a horrific, one of these, that we're calling high-grade B-cell lymphomas that looks Burkitt-y, but we don't know for sure. Has the translocations, and the pathologist is not calling it pure Burkitt's because that would be a different discussion. But Burkitt-like, with lots of extranodal disease, if I have one of those, it would be hard for me to not discuss it in detail with them with high-dose methotrexate, even whether I should intensify therapy, which is something I no longer give dose-adjusted EPOC, but that would maybe even be a scenario. And I haven't had one of those in a while, and hopefully I don't. But that would be a scenario.
Yeah. It's tricky then, isn't it? Because where's your cutoff? An 18-year-old, a 25-year-old, a 30-year-old, a 40-year-old? When you stop? It's really hard, isn't it? And
in Burkitt's, we accept, at least I accept, and but you're right. Maybe it can be ALL. I accept that we need to give it. So especially those lymphomas that have those features, it would still be hard for me to not give it. But if they're over the age of 60, it's a no. There's no one you could give me over the age of 60 that I'm giving high-dose methotrexate.
Do you give it to all Burkitt's, Aaron?
I haven't treated an old Burkitt's in a long time.
I didn't mean all Burkitt's.
I follow the established protocols that are there for Burkitt's to at least tell my patients the expected outcomes if I stay to it. So yes, I do. Whether that makes me hypocritical or not, I don't know. But I follow those protocols.
And we do need, we do need to. Burkitt's is a different piece.
Yeah, there's no question about it.
Yeah.
I think at a very high level, and you've been very generous with your time. We'll wrap up very soon, especially that Aaron is on vacation and he needs to play guitar. But I think my biggest challenge, just holistically in general, when I think about evidence-based medicine and how we practice and so forth, I don't see us resolving all of the questions in oncology or hematology with really prospective studies that are powered. And honestly, you could give me any study and I will find problems in the study, whether it's published in whatever journal. That's why there's always a section of limitations of the study, right? You never write a paper unless you put limitations towards the end. Otherwise, the reviewers will say, bring it back. Because it's the nature of the beast. There are limitations to any study that we do. So I always feel, and that's me, like despite imperfect science, because science is not perfect, we still have to treat that patient in the room that is asking for our help. And, we could talk about p-values and power study and the number of patients, but that Mr. Smith in front of you, he just wants to know whether he should get that treatment or not. And the pragmatic brain of mine struggles in finding a trial for every single question. I mean, honestly, goodness, look how we treat, I don't know, BMT patients. I'm not a transplanter. I did a lot of auto transplant, but Aaron rotates on the transplant unit a lot. And, transplant patients get a whole host of prophylactic therapies and a lot of things that you could argue that maybe we're overdoing it or underdoing it. So I don't know. Part of me is I just don't know if we're ever going to reach that point where we can answer that question.
Yeah, and I agree. I don't think we'll ever answer the question definitively, but I'm going to finish with a bit of optimism. I think there are things that we are and will do that will help. I think that the way we characterize or the way we classify diffuse large B-cell lymphoma is changing. It's maybe not made it into routine clinical practice, but as we know now, we've got much more information on the particular molecular subtypes, and within that, we know there's definitely a molecular subtype that is a particularly high risk of CNS relapse. So I think the way we classify these patients is going to improve, and we may be able to pick out these high risk patients better. And I think the other way that's really interesting area is there's data presented at ASH, looking at circulating tumor DNA in the CSF, and back to Aaron's point about, surely these patients have occult disease there at the beginning. And there was a study published at ASH where they took a big cohort of DLBCL and looked back at their diagnostic CSF. And first of all, they took out patients who did actually relapse in their central nervous system, and they were able to use their circulating tumor DNA technology to detect disease in the CSF there where normal CSF analysis had failed. And they also took a very high-risk group of patients with all these kind of high-risk features we talked about, and they were able to find occult circulating tumor DNA in CSF in 40% of them or something. So I think we will get better at picking these patients out. I think we have to, and whether we'll actually find a prophylactic treatment that benefits them, I just don't know. But I think there are areas where we can improve.
Aaron, I want to finish with the closing statements for each of you, but I want to just maybe ask you a provocative question because, I'm not a big fan. I'm okay fan, but not a huge fan of clinical factors. Like when you look at CNS IPI, there's LDH and performance stats, age, whatever it is, but all of these are clinical factors and they're good, they're important. But what if you have a particular genomic prototype or a particular profile that is looking at, again, genomic level of overexpression, underexpression. Similar, if you remember, 20 years ago, when we were able to find that some patients with DLBCL they're actually Burkitt's, and some Burkitt's are DLBCL. If you remember Sandeep Dave, who's currently at Duke, he published that a long time ago. And that profile, that genomic profile, identifies to you a subset of patients that are at the highest risk of CNS disease. Wouldn't that sway you a little bit differently? Because now you're really taking away that, you're looking at the biology of disease more than anything else.
It all depends on the positive predictive value. If you could show me in a group of patients that it's picking up, my big thing is over-treatment of cured patients. And with our current strategies, I think we all agree that you'll be largely treating people who don't need it with high-dose methotrexate. So yeah, if you had some genomic thingy, that, some NGS or whatever that showed me that these are the people who are all getting it. They have this, maybe MYD88 or whatever mutation it is or combination that they got rid of more subjective like measures, performance status and things like that. Even LDH, on a given day, it can vary. Then yes, I would be more inclined to use it because then I know I'd be treating, at least I could accept that I'm treating less patients who don't need it. Whether it's helping or not would be a different story, but I'd feel better about it. Okay. Yeah. And I think, to answer your question, especially, with the transplants, you're right. A lot of the stuff we do is without data, and it's your comfort level of using the data, of using treatments in certain settings. For me, my comfort level has changed when it's giving therapies, and I'm repeating myself, in the maintenance setting or to prevent other things. I'm just now requiring a higher level of evidence for me personally, because I know with certainty that the additional therapy will have issues. I mean, I can give an example. I used to transplant all T-cell lymphomas in CR1. I'm no longer doing that. Now, there are some exceptions, but I'm largely no longer doing that because I came to the conclusion, I was like, I'm gonna give someone an auto freaking transplant who doesn't need it like that. That was like, oh my God, and we really don't have a definitive data that answers that question. So I've changed, and maybe I'm wrong or not, and that's a whole other debate. So, but that was supposed to be my conclusion. Yeah.
You are a Papa Heme, so you can't change.
Well, I'm learning, and I'm first to, I would love to be shown, I change my mind a lot when and I'll admit when I'm wrong. And, but right now I stand by the no-high-dose methotrexate.
All right. So 60 seconds, closing statements. Matt, you go first.
Okay. Yeah. Well, I've in part been playing devil's advocate during this debate. I wish I knew what the answer was. I don't think neither of us know. None of us know. But I do still think that the cumulative body of evidence is there to support giving high-dose methotrexate to prevent a very devastating outcome for our patients. And I think that there is the emerging evidence that's trying to question that, is trying to disprove it, is not sufficient yet to drop it. I think as we've discussed, we do need to be very careful about how we select patients for this treatment. It can be toxic. I think we are going to improve on how we select these patients in time. And I hope that we can maybe someday carry out a prospective study that could demonstrate a benefit, whether that's high-dose methotrexate or a novel agent. That would be ideal, wouldn't it? But right now, my position is that I want to prevent a very devastating event, even if it's for a very small number of patients, and I don't have enough evidence to say I shouldn't do that.
Closing statements, Aaron, 60 minutes or less, 60 seconds.
60 minutes. So I could talk for 60 minutes further on. It's super rare. Okay, so I think we can all agree on that. The majority of patients with DLBCL who are going to die from their disease, it's going to be due to systemic relapse and not CNS relapse. We have no agreed upon categorization to define who truly is high risk. It varies among centers. It varies within centers on how we define that. I still contest we don't know the most effective way to treat these patients if we are going to accept the need for it, whether it's intrathecal or high-dose methotrexate, although no one's giving intrathecal anymore. If we accept high-dose methotrexate, do we give 1, 2, 3, 4, 5, 6? What's the magic number of cycles? Is 1 just enough? And finally, we know with 100% certainty that giving additional therapy results in additional toxicity and expense and unpleasantness for the patients. And we do not know, I think that the level of evidence isn't as great as my colleague does, although that's up to interpretation. And for those reasons, I do not recommend intrathecal high-dose methotrexate CNS prophylaxis for DLBCL.
Okay, well, I'm glad that we resolved the issue. So if you are a listener, it's very clearly we resolved. First of all, I want to thank both of my guests. I want to thank Matt, who is, I just learned today that you have a 1-month-old baby, so you're barely sleeping and you're calling from the UK. So it's pretty late. It's close to 9 p.m. or 10 p.m. your time. So we appreciate that.
I'll be up for hours yet, so don't worry about that.
Yeah, versus Papa Heme is on vacation. He's just basically drinking and playing guitar and wearing AC/DC tank top. So pretty much, Aaron.
Yeah, I have a hard afternoon at the pool right now.
We're very jealous, but apologies to your family because we took you away from you on time of vacation. Looking forward to connecting with you online and hope we'll air this episode in a couple of weeks. Thank you so much, guys.
Thank you.
Thanks, guys. Cheers.
Nice meeting you, Matt.
Yeah, good to meet you.